All right, let's talk about something that isn't just a topic in your textbook. It's a real-world clinical puzzle you will face: bleeding during pregnancy. Knowing how to piece together the clues is an absolutely critical skill, and in this explainer, we're going to give you the framework to solve it.
First things first, this right here is the golden rule. You have to burn this into your brain. Any bleeding at any time during pregnancy is considered a red flag until you can prove it's not. It demands an immediate and thorough investigation because we're talking about the health of both the mom and the baby.
So here's our game plan. We're going to tackle this just like a clinical investigation. We'll start with why bleeding is always a warning sign. Then we'll dive into the causes based on when it happens, early versus late pregnancy. And finally, we'll lock in exactly what you need to do.
So where do we even begin this investigation? Well, the single most important clue you have is when the bleeding is happening. The timing, the gestational age, it dramatically narrows down the list of suspects and guides your entire assessment from the get-go.
See what I mean? The timing is your first major clue. If it's early on, in the first trimester, your brain should be thinking about things like a miscarriage or, more urgently, an ectopic pregnancy. But if the bleeding starts later on, your focus completely shifts to problems with the placenta, like Previa or Abruptio. Let's start with that first trimester. Okay, so a patient comes in, they're in their first trimester, and they're bleeding. Your mind needs to immediately cycle through three primary suspects. Let's break down the unique signs for each one, because spotting them quickly is absolutely critical. Our first potential cause is spontaneous abortion. Now, clinically, that's the correct term you'll use in your charting, but when you're talking to your patient, please always use the word miscarriage. It's so much clearer and more empathetic during what is, a really traumatic experience for them.
Okay, now look closely here. Notice how the status of the cervix is really the key differentiator. In a threatened miscarriage, the cervix is closed. There's hope. The pregnancy might still continue. But with an inevitable one, the cervix is open. It's happening. And understanding the difference between, say, an incomplete and complete miscarriage is crucial, because retained tissue is a huge risk for infection and hemorrhage. All right, next up is ectopic pregnancy. And let me be clear, this is a true medical emergency. The fertilized egg implants somewhere it shouldn't, usually in the fallopian tube. As it grows in that tiny space, it's basically a ticking time bomb that can rupture the tube and cause a massive internal bleed. This right here, this is the classic triad you have to know. A patient tells you they missed their period, they've had a little spotting, and, this is the key, they have a sharp, stabbing pain on one side of their lower abdomen. That combination should set off major alarm bells for an ectopic pregnancy. Now, if that patient mentions shoulder pain, you are witnessing a sign of rupture. That's not a pulled muscle. It's referred pain. It means blood is leaking inside and irritating the diaphragm. That sign, plus any dizziness or signs of shock, that is a surgical emergency right now. Okay, finally, for the first trimester, we have the rare but very serious gestational trophoblastic disease, or a molar pregnancy. In this case, there's no viable fetus. Instead, abnormal placental tissue grows, and it can sometimes become cancerous, which is why follow-up is so incredibly important.
The clues for a molar pregnancy are really distinctive. The uterus measures much larger than you'd expect. Why? Because of all that abnormal tissue growth. That tissue also pumps out sky-high levels of HCG, which explains why these patients often have severe nausea and vomiting. And the bleeding itself often looks like dark brown prune juice. It's a very classic picture.
All right, let's shift gears. We're moving into late pregnancy now. If your patient comes in with bleeding in the second or third trimester, your whole list of suspects changes. We're not thinking about ectopics anymore. Now, our investigation is all about the placenta.
First up, placenta previa. This is basically a geography problem. The placenta is in the wrong spot. Instead of being high up in the uterus, it's down low, covering the exit, the cervix. So as the cervix starts to change later in pregnancy, it can tear those placental vessels, and that's what causes the bleeding. If you remember just one thing about Previa for your exams, make it this phrase: bright and painless. The bleeding is bright red, and crucially, there is no pain. The uterus is soft, it's relaxed. That absence of pain is just as big a clue as the bleeding itself.
Next is Abruptio placenta, which is the placenta prematurely tearing away from the uterine wall. This is a major emergency. It cuts off the oxygen supply to the baby and can cause severe maternal bleeding, and sometimes that bleeding is hidden, concealed behind the placenta where you can't even see it. And the classic sign here? It's the complete opposite of Previa. It's dark, pain, and rigid. The blood is dark red, the pain is sudden and intense, and the uterus feels rigid, like a board. That's because blood is getting trapped behind the placenta, which is incredibly irritating to the uterine muscle.
Being able to tell these two apart is one of the most important skills you will learn, I promise you. Your first assessment at the bedside can point the whole team in the right direction. And believe me, those seconds matter. This table right here, this is your clinical cheat sheet. You have to know this. Previa versus abruption. Is there pain? Previa is painless. Abruption is agony. What color is the blood? Previa is bright red. Abruption is dark. What does the uterus feel like? Soft with previa, rigid with abruption. These questions will lead you to the right answer in a crisis.
Now let's talk about a rare one, vasa previa. And with this condition, the biggest danger isn't to the mother's blood volume, it's directly to the fetus. It's not common, but you have to know about it, because the outcome can be catastrophic.
So with vasa previa, the baby's own blood vessels, the ones from the umbilical cord, are exposed. They're just draped across the cervix, with no protection from the cord or the placenta. So when the water breaks, those vessels can tear, and that causes a rapid fetal hemorrhage. And this is the key takeaway. In previa and abruption, we're managing the mother's blood loss. But in vasa previa, the blood is coming from the baby. A small amount of bleeding that would mean nothing to an adult can be fatal for a tiny baby who has such a small total blood volume. It's an extreme emergency. Okay, we have gone through all the possible culprits. Now, let's bring it all home. What is your role? What are your priority assessments and actions? This is where all that knowledge turns into life-saving intervention. So let's do a quick recap. For placenta previa, it's bright and painless. And the absolute #1 rule is you never, ever perform a vaginal exam. For abruptio placenta, dark, pain, and rigid, you're preparing for an immediate birth. And for every single one of these conditions, your core job is the same. Monitor vitals, assess the bleeding, and provide that crucial emotional support. We've given you the framework, the clues, and the patterns. But remember, the color of the blood, the presence of pain, the feel of the uterus, these are your guides. Your ability to perform a rapid, accurate assessment is the skill that saves lives. So in that critical moment, which one of these pictures are you going to recognize first? Being ready for that question is what this is all about.